Welcome, everybody. On behalf of the North American SCI Consortium, I'd like to welcome you to this special webinar that we have planned today. I think, as the title goes, for many of us living with spinal cord injury, we really do appreciate how important it is in maintaining respiratory health after a spinal cord injury. Today's event is sponsored by Synapse, and Synapse is one of our founding partners with the North American SCI Consortium. For those that you don't know, Synapse Biomedical was founded in September of 2002 to commercialize the product Neurex, which is a diaphragm pacing system, which has been developed during a 20-year period in collaboration with Case Western University and the University Hospitals of Cleveland. This innovative research performed at these institutions has led to significant advances in the state-of-the-art electrical stimulation for treatment of chronic respiratory insufficiency. And we, as people with spinal cord injuries, really do appreciate the work they've done. This is not an infomercial, just so you know today. It just brought to us by our friends at Synapse and to help us better understand the importance of respiratory health. And so I welcome you all today for this great webinar. This webinar will be available as well afterwards on our website and will be in our archive section. So the agenda for today is you got me welcoming you, as well as you're going to next, after our introduction, hear from Jeff Thompson, Dr. Jeff Thompson, to talk about the importance of respiratory health and SCI. And then we're also going to have some great panelists, people with lived experience that have spent and rely upon the assistance of devices to help with respiratory issues. And we have Karen Mills, Justin Matthews, and Christine Matthews. And then afterwards, once we've heard their stories, we're going to open up to all of you for questions. Please feel free to put questions in our chat as well. We will field questions as if you put your hand up or even to speak out. I would like you to all please mute your microphones. And then if you can later on, you can speak up if we don't recognize a hand wave or something in the chat. So that is going to be our next hour, and I hope you all enjoy it. We wanted to let you know about how we got here in the first place. So we at the North American SCI Consortium were really formed in 2018. As you can see, we're a grassroots advocacy group, and it really was about bringing the community with SCI together. And we wanted to be more active and united in our efforts. And unfortunately, what we found is in the world of SCI, we're very fragmented in terms of our organizations and how we work together, but frankly don't work together. But the work of NASCIC has really brought us all together. We have 58 community-led organizations, 292 individuals with SCI, and 86 partner organizations in the SCI field, like our friends at Synapse. And our mission is pretty straightforward: to bring about unified achievements in research, care, cure, and policy by supporting collaborative efforts across the spinal cord injury community. And we achieve this really by identifying the gaps, communicating resources, and by doing that, we share resources from all corners of the continent that some people just might not know of. But more importantly, my favorite line is that we are a conduit for collaboration. We're here to bring people together and to help share knowledge that can help us all improve our lives. And between the community and people living with SCI and the many stakeholders that are involved in SCI. So that is really what we do here at NASCIC, which includes hosting webinars like this with the friends and help of our friends like Synapse. So I encourage any of you, if you want to join NASCIC, you can join as an individual in SCI, or if you're part of an organization that deals with spinal cord injury, you can also join in that capacity as well. The QR code is here, and we will show it at the end of our presentation today as well. So let's start. I'd just like to introduce Dr. Jeff Thompson, who is a clinical service.
I'm not a doctor, respiratory therapist, but thank you for the promotion.
No problem. I have a private med school that I host, and for the right price, I can give you whatever you want, Jeff. Thank you. Thank you. Yeah, so as a respiratory therapist, he's a manager at Synapse. Jeff began his career in respiratory therapy 28 years ago. And for the past 16 years, Jeff has worked extensively in medical device research and is a subject matter expert on the NeuroX diaphragm pacing system. He has personally participated in the treatment of over 350 patients implanted by the NeuroX diaphragm pacing system in US, Canada, Europe, Asia, and the Middle East. So I invite you, Jeff, to take it off and go ahead.
All right, as soon as I can figure out technology on how to get my screen shared.
You should have the ability to share your screen.
And how's that?
Here it
Everybody
comes.
see that one?
Yeah, great.
Okay.
Perfect.
And now my end is not working. Okay, well, I'm gonna just wing this. So, thank you to the team at NASCIC for putting this together today. It's an important topic that probably should be covered twice a year at least. I'm here in Cleveland, Ohio, and it's allergy season for us. So some people with spinal cord injury may be experiencing the same allergies problems that we are here. But today we're going to be talking about respiratory health after spinal cord injury. Now my screen is not moving. So for some reason, my whole system is locked up. I'm going to try to reboot this and see what happens here.
I was just going to say, yeah, if you want to stop sharing and then try and share again.
Not a problem.
And okay, so now
The other option.
let's try that one. You getting that one now?
Yes, we are.
Okay. Okay. See there, I see where the problem lies. For some reason it's wanting to run as a slideshow. Okay.
If you want, Jeff, you can always send the presentation to Jessica and she can run it for you if you want.
And for some reason, mine seems to be freezing up when I try to play it. Share screens. One more time. Okay. There, how's that? Now is it moving?
Yes.
Okay, great. All right, got it fixed out. So conflict of interest disclosure. My name is Jeff Thompson. As Barry said, I'm a clinical services manager for Synapse Biomedical. I've been working for Synapse for 16 years, respiratory therapist for 28 years, with most of my career spent in spinal cord injury. I've been working for Synapse, which manufactures the diaphragm pacing system since 16 years. Today's objectives, what we're going to do is we're going to go over an SCI overview of injury a little bit. We're going to discuss respiratory health after spinal cord injury, breathing assistant options for those living with cervical spinal cord injury. And then, as Barry mentioned, as the agenda, we're going to discuss and we're going to have a discussion and Q&A with people living with cervical SCI. This slide here is staggering. 18,000 new injuries a year, approximately. These are based on the 2022 statistics from the National Spinal Cord Injury Statistics Center at UAB. But what's more even staggering is almost 60% of these injuries result in some form of tetraplegia. If the level of injury results in a need for prolonged mechanical ventilation, it's even more staggering that life expectancy is so greatly affected. When you look at someone, say, for example, it's 40 years old, if they survive the first 24 hours, their life expectancy is 8.8 years. If they make the year, then they can expect 13.2 years. These are statistics from the Statistics Center. That's staggering because the ventilator dependency affects their life expectancy so much. So with spinal cord injury, when we look at it in general, it's important to recognize that the level and completeness of injury profoundly affect muscle control. Signals from the brain, they can't transfer down to the muscles, and the brain can no longer control them. It's important to remember that the higher and more complete the injury, the greater the loss of muscle control and respiratory impairment that the person is going to experience. For people with cervical spinal cord injury, it results in an absence of or reduction in breathing capacity or an absence of an effective cough. So in talking about respiratory health after SCI, what I'm going to touch on is four topics that I pulled out of the many topics we could cover. But regardless of the level of injury, I can't stress enough the importance of maintaining and managing your respiratory health. We're going to talk about respiratory infections and secretion management, lung collapse, which is also called atelectasis. The last two may slip under the radar when we talk about respiratory health, and that's pulmonary embolism and sleep apnea. So respiratory infections, it's been well documented for many years that pneumonia and complications from respiratory infections are a primary cause of death for people with SCI. And it's very, very important to remember that the higher of injury, the greater the risk of contracting respiratory infections. It's very important, regardless of your level of injury, to know your warning signs, and they vary from each individual. It could be anything from fatigue, breathlessness, chest tightness, wheezing, fever, increased episodes of AD, and an increased need for suctioning for those with cervical injuries that have tracheostomies. Some of the do's and don'ts when it comes to respiratory infections: you need to monitor your color consistency and amount of secretions you're producing. You know what your baseline is. Say, for example, if you get suctioned twice a day normally, and all of a sudden you start to find a need to be suctioned 5, 6, 7 times a day, that could be a cue that you have some type of respiratory infection going on. You also want to avoid buildup and secretions in the lungs, and I'm going to talk more about that in the next slide. It's very important to stay hydrated, and I know that's difficult for some, but please remember, drinking water helps thin your secretions and helps you better manage them. Stay away from people that are sick. That is very important. Don't smoke. If you stop smoking, great. If you haven't started, that's great. Don't start, but just make sure you stay away from smoking. You want to strongly consider yearly flu shots, pneumonia shots. Those are very effective in help reducing your intensity of an infection if you get it. And please communicate with your physicians early and often. Shockingly, many people with spinal cord injury return home and don't establish a system of care. And recently a patient revealed to me that he had not seen a physician in 10 years. I can't stress enough, your relationship with your physicians may save your life someday. Don't wait to meet your new physician in the ER. Start now, be proactive, find a good primary care physician, a good pulmonologist, a good physiologist, someone that can help you maintain your level of health and your level of activity. And when talk about secretion management, it's important to know that muscles responsible for producing a cough or effective cough may no longer function depending on your level of injury and the completeness of your injury. Controlling excessive mucus requires proficient secretion management. By that, I mean, there are 4 primary ways of controlling secretions. Suctioning, obviously, being the most invasive. You have mechanical and manual cough assists, which are very, very useful and effective in managing secretions. Percussion and vibration can also be done. And the least invasive postural drainage is probably one of the ones that is not done enough. If you have a consolidation or infection in, say, your left lung, you want to lay on your right side so that left lung drains. That's what postural drainage, part of what postural drainage is. And if possible, utilize breathing and cough exercises if you've been trained in those. Lung collapse or atelectasis can occur because of lack of secretion clearance, and it could affect all or part of a lung may collapse. You typically, for those that are less active, sedentary, and especially for cervical injured people that are on mechanical ventilation, the bases of the lungs may collapse. And that's typically where it starts for most people. The cause is caused by impaired or ineffective secretion clearance. Again, your symptoms might mimic those for your respiratory infection. You may have some difficulty breathing, wheezing, coughing, more frequent suctioning. Use appropriate methods of secretion management. And again, I'm not here to tell you one way of doing it is better than another. Whatever you found to work for you, make sure you keep using and utilizing those methods. If you haven't found something that quite works so well, again, communicating with your care team is very important to keep your lungs healthy. And again, if possible, utilize breathing and cough exercises. This one doesn't get talked about very much in spinal cord injury, and it should. Obstructive sleep apnea, that's a loss of muscle tone in the tongue, soft palate, and or throat. And what it results in is a collapse of the airway, which obstructs the flow of air. Some common symptoms include loud snoring, morning mouth dryness or a sore throat, morning headaches because you're not breathing effectively, carbon dioxide builds up, daytime sleepiness. Other symptoms may include that you find that you can't pay attention, or you can't focus, you're irritable, which is normal for me. But it's important for you to know these common symptoms. Importantly, weight management. I took care of a young man many years ago, his C1 quad, took him home on a vent. He was at age 16. He weighed 167 pounds. He died at age 23 at the weight of 306 pounds. The family just didn't think that it was a big deal because he had lost so much of his mobility that he was gaining this much weight. Come to find out that it was the weight that killed him. So manage your weight and get evaluated if you have any of these signs and symptoms, because it's very important. Sleep is very important part of respiratory health. And the last one I'm going to talk about briefly is pulmonary embolism. You're at highest risk for this within the first 2 or 3 months of your injury. We're going to talk about the way that a pulmonary embolism happens, and it starts out typically as a deep vein thrombosis or a DVT. I'm sure you've seen the commercials all over about DVT medications. It's important to know the signs of a DVT. You may have swelling or redness, pain in the arm or leg, and yes, a DVT can start in your arm. So that's something to be constantly aware of. The area may become warm to the touch. You may experience a fever, increased episodes of autonomic dysreflexia. So it's important to pay attention to those signs, especially for those that are quarantined to a wheelchair because of their injury. If that DVT progresses up into the lungs, it becomes a pulmonary embolism. That's very serious. Blood clots from the legs that get stuck in the arteries in the lung can and typically do kill people. So it's important to know these things. Some of the signs and symptoms of a pulmonary embolism are sudden chest pain or tightness, especially when you try to take a breath in, shortness of breath, rapid shallow breathing, you just can't get enough air, bloody mucus may be found, and fever. It's important, and I can't stress it enough, to establish your care team and stay in contact with them, because they're the ones that are going to keep you out of the hospital, and that's the last place we want anyone to be. Now, I mentioned earlier, we're talking about level of injury and how it greatly affects respiratory muscles and impairs your ability to breathe and cough. Particularly now, I'm going to talk about spinal cord injury that occurs in the cervical area. C1 through C3, when we look at these highest levels, typically an injury like that will result in full-time dependence on mechanical ventilation, and that's due to the paralysis of the diaphragm and all of the respiratory muscles. They will have poor or no cough if you suffer from this debilitating injury, and that's due to the diaphragm paralysis, and again, the accessory muscles that are no longer functional. If you have a cervical injury between C3 and C4, full-time ventilation initially, and you may possibly wean from mechanical ventilation to partial use, where you might be off for some time of the day and be on mechanical ventilation at night. Diaphragm function and other key muscles are impaired because of the injury to C3 and 4, and this results in an ineffective or an absent cough or breathing. So again, these levels of injuries typically will result in prolonged need for mechanical ventilation. There's a saying in the community that C3, 4, 5 keep the diaphragm alive. So it's important to know that your level of injury and how it affects your breathing and ability to cough. And then C5, like I mentioned, you're going to start out full-time use of mechanical ventilation initially. That's very common for spinal cord injured people, and then possibly wean from mechanical ventilation. Again, it depends on the level and the completeness of your injury. Your diaphragm function may be intact, but paralysis of your key respiratory muscles may result in an ineffective cough. So again, it's important for secretion management to know methods on how to control your secretions. Now, I mentioned mechanical ventilation. Options are limited regarding standard of care for high-level spinal cord injury that are on mechanical ventilation. You're left with pretty much a positive pressure via tracheostomy, which remains the standard of care. This is initiated early on in injury and can last throughout the entire lifetime of the person living with the injury. There are some people that do heal and get their tracheostomy removed. And non-invasive ventilation via a chest cuirass, it's called negative pressure ventilation, a mask or a mouthpiece in the picture there on the right. I've taken care of a couple of patients with that kind of a setup where during the day they didn't need full-time ventilator assistance, but when they got short of breath, they would just bite down on the mouthpiece and the ventilator would deliver breathing. And this is the standard of care, but the standard of care can be disrupted. And that's by using diaphragm pacing. Now, diaphragm pacing isn't some new approach that just came out. Actually, on November 4th of 1818, a Scottish chemist decided it was a good idea to take a lifeless corpse from an executed prisoner, executed murderer, and hold two metallic rods charged by a 270 plate voltaic battery to various nerves, which is, according to the people that were there, resulted in a body convulsing and shuddering in a grotesque dance of death. Now, ironically, diaphragm pacing, in this event, Mary Shelley's Frankenstein was first published in January 1st of 1818. So I don't know if he got the idea from reading the book. Who knows? Maybe someone out there may know, but I think that's where he got it from. Over the years, diaphragm pacing has been investigated for a variety of conditions: asphyxia, cholera, polio. And in the 60s, Dr. Glenn and Associates pioneered the use of direct phrenic nerve stimulation for long-term stimulation for high spinal cord injured patients, and established the use of this type of stimulation for congenital central hypoventilation syndrome, which is popular more so in children than adults, but adults can't have that condition. So for today, the primary indications for diaphragm pacing are respiratory insufficiency due to neuromuscular injury or condition. And the most common cause of cervical spinal cord injury is at or above the C5 level. These are the people that would most benefit from diaphragm pacing. In today's preoperative considerations, the first and foremost is you have to have an intact phrenic nerve. And that is a nerve that originates in C3, 4, or 5 in the cervical area. Patients that they may be considering use of diaphragm pacing, they can be tested to see if that nerve is intact, either through a phrenic nerve conduction study done by a neurologist, a phrenic nerve stimulation under fluoroscopy, again, a neurologist with a radiologist is involved, phrenic nerve stimulation with ultrasound, direct diaphragm stimulation, which is called mapping for the Neurics system, during a diagnostic laparoscopy. The bottom line is diaphragm must respond to electrical stimulation. The second most important preoperative consideration is motivation. The person with the injury and is on mechanical ventilation has to be the most motivated person in the room. If they're not motivated to get off the ventilator, chances are it's going to be a rocky progression to get them off of mechanical ventilation. They have to be their own cheerleader, their biggest motivator. And that is extremely important because, again, I can cheer from the sidelines all I want, but if someone with a spinal cord injury on mechanical ventilation doesn't want to get off of mechanical ventilation, there isn't much anyone can do. So diaphragm pacing today, the current available technology here in the United States, again, is Synapse Biomedical, our Neurex diaphragm pacing system, and the Avery Biomedical devices out of Comac, New York, I think they're still there, of their systems as well. But regardless of which system is utilized, the objectives are all the same. The device and the companies and the people that implant these, we want to promote natural ventilation with the patient's own diaphragm, because that makes them, that's right there, that's going to make them healthier. We want to impact life expectancy. If you're on mechanical ventilation, we know mechanical ventilation can cause pneumonias and other problems. If you're not on mechanical ventilation, if you're using your natural filter and humidifier, that can impact your life expectancy and improve your quality of life. It's important that you're able to have the freedom to go out and do things that you want to do. And diaphragm pacing can help establish that for you. So again, my name is Jeff Thompson. I'm a registered respiratory therapist. There's my contact information if you want to reach out and talk about anything that we've discussed today. And Barry, it's back to you.
Thank you, Jeff. That was a great presentation. And just to remind our viewers again that this is taped and it will be provided at a later date. And all of you registrants today will be notified of the proposal in the archive. So I guess we'll need you to bring it back to Jess. Take over to share the slides.
Yeah, Jeff, if you could just stop sharing your screen and then I can share mine again.
Yeah, well, working on that. For some
Okay.
reason, Cody. It's kind of comical. I can manage mechanical ventilator, but I can't manage the Zoom call. I actually have lost the entire Zoom. This is all I have.
Right. Can everyone see that?
No.
No? Okay.
I'm working on getting rid of.
Okay.
I've never seen this happen before. I tell you
Oh,
what,
I think I can do it for, it's good. I can do it for you.
Okay, I was gonna say, if you can, I'm gonna bow out of
I'm gonna do,
the.
yeah, I was just like, I think I can do it for you. I'm leaving the meeting.
Okay.
Okay.
Yes,
Okay.
that's your screen now.
All right.
Yay.
Well, thank you, Jeff. Now,
Thank you, Jess.
we move on to real life experience and really people that we can't help but admire for your courage and your strength. And thank you so much for coming today and telling us about your experience and your journey through all of this. And I want to introduce to you our first guest, Karen Mills. Karen Noreen Mills is the director of the Legal Services Division at the California Farm Bureau Federation. She has worked at the Farm Bureau since 1988, representing its members' interests during the time myriad of energy issues which arise in the course of proceedings at the California Public Utilities Commission and the California Energy Commission, as well as the legislature. In 2019, Karen was riding a horse when she tripped and she went over her head and landed in over the horse's head and landed in a very unfortunate position. Karen would later discover that she had suffered a C2 injury, which impacted her ability to breathe on her own. When her family was being asked to make decisions about rehab facilities, they became aware of the diaphragmatic pacemaker and how it might suit her. She was transferred to Santa Clara Valley Hospital and in November of 2019. There, she met Jeff Thompson and Dr. Anders of Synapse, who oversaw the implementation of the pacer. Synapse has provided important support to her and her family as they navigate recovery. Karen continues to gain function and looks forward to breathing on her own, which process has been aided by the pacer. So thank you for joining us, Karen, today, and we invite you, if you could, to tell us your story and your journey.
Sure.
Pacer. Thank you.
Thank you, Barry and Jeff. And Jeff, man, if I'd seen some of those slides and points you made, I would have been a little bit less optimistic as I started the journey. So it was good that it was after the fact. I mean, thank you all so much. I mean, at the outset, I thought I'd just point out a couple of ludicrous things that we found when we were in the hospital. It's also good, always good to start out with kind of recognizing what we're facing. You know, Jeff mentioned how important it is to sleep, and I constantly got asked why I wasn't sleeping better during the night at the hospital. And of course, it's because you got interrupted so many times, and there were a lot of other commentary that was frustrating, and the most of which was the hesitancy of any of the mainstream medical professionals to offer any kind of hope for improvement from my injury. But fortunately, family member support and friends overcame that viewpoint. I was 63 when I had my injury, married for over 40 years. And so I had an established life with lots of hobbies and activities. So like for everybody, it was a big jolt. As Barry mentioned in the bio, I was just doing a very benign activity when I had my injury. Fortunately, there was a firefighter in my riding lesson with me who saved me and was able to administer life-saving CPR. But as I was in the hospital for a number of weeks before being transferred to Santa Clara, my husband and brother-in-law became aware of the pacing system and pushed to go to a facility where it would be an option. And of course, as Jeff pointed out, there were a number of, considerations before it was implanted. The most of, not the least of which is the recognition of how much support I would need to have at home. But our awareness about the pacer, we pushed for it as a pathway to make life a little bit more manageable. And as we learned about it, and we pushed hard, and it was supported by Synapse, which we were appreciative of. And so it's had a tremendous positive effect for me for being able to go to work, to do activities, because the transportation is so much easier without being on the vent. And I go to meetings, I work. I go to my office about 3 times a week, which I'm still practicing as an attorney. And that makes it doable. When I go to the office on those days, I'm usually on the pacer for about 10 hours a day. I go on the vent at night as a break, and also because it's a little bit more obvious if something goes wrong if you're on the vent. But we pushed hard to make the pacer happen, and we appreciate it. And it was not a insignificant transition to build up to being on the pacer for long periods of times. It requires some strengthening, so you just got to push hard and push through it. And fortunately, I have a daughter, Emily, who has in her mind how things need to be done, and pushed hard for me to do that. I think one of the most important things about the pacer is it allows me to get outpatient physical therapy, which in Sacramento and my healthcare system, they would not offer outpatient physical therapy if you were on a ventilator. And so it makes it feasible. And of course, the physical therapy is such an important part of gaining improvements. I had the pacer implanted in November of 2019, and a month later, I got my first movement back. My big toe started moving, and I have improved very slowly ever since then. All the improvements related to this injury are terribly slow. And as Jeff pointed out, the diaphragm pacemaker does have an impact on my respiratory health. I've always been able to cough, but the pacer seems to stimulate. And, I'm no medical person, so what do I know? I just speculate a lot, but it does seem to push harder down farther on the lungs. And so it helps in pushing forward any kind of fluids or anything. Very helpful. But anyway, all of the needs that you have to take care of with doctor's visits or other kind of requirements, it's so much more feasible to do the transportation when you don't have the ventilator attached to the wheelchair. I think at this point I'll stop and allow for Justin and Christine to go, and then we'll have time for questions. I do point out the picture I provided was a little bit old. It was before my injury, so don't judge me for being vain. Thank you.
Oh, thanks, Karen. No one's going to be judging you for that. The
Yeah.
more we do that, the better. But thank you so much for sharing with us what you've been through. And as we said earlier, we're going to hear from Justin and Christine. And afterwards, we're going to open it up for questions and answers by all parties, as well as you from the audience to ask the questions specifically. I don't think there's any question. Well, we'll moderate that. That would be something that this group's a really great group and really here to share. So I'd like to really introduce our next dynamic duo, frankly, is Justin and Christine Matthews. Justin and Christine are advocates for SCI research and community services. Justin was injured at the C1, C2 level in 2019 after being struck by a car as pedestrian. 3 months after their wedding. Despite the severity of Justin's injury, the two made a life of themselves for themselves and pivoted in each of their careers towards healthcare. The Matthews are on the Consumer Advisory Board for Neuralink, and Christine serves serves on the McGee Rehabilitation Hospital Patient and Family Advisory Council. Christine is the Vice President of Business Development and Strategy for Utilize Health, a care management company that offers coordination of care services to individuals living with SCI and brain injury, stroke, and other neurological conditions. Prior to his injury, Justin was Vice President of the Decision Sciences team at Universal McCann. He now mentors others living with spinal cord injury and produces music in his spare time. Welcome, Justin and Christine, and the floor is yours, and please feel free to tell us about your journey and what you've been through. Thank you.
Thank you. Everyone, my name is Justin. It's my wife, Christine, and first off, I would just like to thank Jen, Jeff, and Eske for the invitation today. So yes, I was injured back in 2019 and remained in acute care in New York immediately after my injury for 3 months until I was medically stable. At which point Christine and I and my parents decided to relocate to Philadelphia, to McGee, for rehabilitation. During that time, we were educated by McGee, and funny enough, by a childhood neighbor who was a thoracic surgeon. His name was Mark Ginsburg, who implanted diaphragmatic pacing systems. So over the course of the next several months, we were educated the Avery diaphragm system, which I was implanted with about 6 or 7 months after arriving in Philadelphia, which was around June of 2020. And since then, I think there have been a lot of benefits to the implant, as Karen mentioned, mobility being a very important benefit. As I transfer from my bed to my wheelchair every day, there's not a need to be or obstruction of being connected to tubing. As I make that transfer tubing and wires getting in the way. Most importantly, I think I do have the pacer connected to me at all times. So while I'm on the pacer during the day, and the ventilator at night, if there were ever an emergency with the ventilator for some reason, the pacer almost acts as a emergency backup. That if I were ever at risk of being disconnected from the ventilator, I know that I have the pacer as a backup that can be turned on at any point. And actually, we've run into some issues, with the power going out, in my house, and the ventilator being turned off or being short on battery, at which point we turn on the pacer, and it's been a lifesaver for me to be with. So it's provided many benefits. Just to summarize, acting as a emergency backup and providing mobility and independence as we move about from bed to wheelchair, and from wheelchair to getting into the van and going outdoors. So I would say those are probably the main two benefits, and I'm sure Christine, my wife, can introduce herself as well.
Yeah, thank you.
So,
Thank you all for having us. As Justin mentioned, the Avery phrenic nerve pacer that he has been hugely valuable to his life and our family. Very easy to use. I would say his was implanted within the first year after his injury, which we were always encouraged and told that the earlier you get the device implanted, the greater length of time you might be able to be on the device more quickly, which, to us, getting him off the vent as much as possible to reduce his risk of respiratory illness was huge for us. And the main difference between these two devices, and I'm sure Jeff can go into this as well, that the Avery device, it stimulates the phrenic nerve, whereas the Synapse device, if I'm correct, stimulates the diaphragm. So nerve versus muscle being stimulated in each of these. And I don't know if the synapse still has some external wires that come out of the skin, but at least when we were considering which device to get, that was the main difference, was that the synapse had some external hardware that was coming out of the body, whereas the Avery has almost like circular electrodes that hover above and get taped above the surgically planted devices that stimulate the phrenic nerves. And in Justin's case, they actually took nerves from his lower legs in order to kind of supercharge his phrenic nerves so that they would stimulate his breathing even better than we had hoped. And his surgery was through Jersey Shore Hospital around the Ocean Grove, Jupiter area of New Jersey. And we're happy to answer any questions about, using the device, our experience, and anything we can to help the community.
Well, thank you so much for all of your presentations. We do have a few minutes for questions and answers, and we'll carry it over a little bit past the hour because we did start a little bit late, and I think it'd be great to hear more from our guests today. Is there any questions out right now? I have one that I'd like to ask, maybe, and I have one. This is from Louise Russo, who says, maybe Jess, you could read off the questions to me.
I did not receive that question, so it may have been directed to you.
Yes, it was. Is it necessary to get the 10-year pneumonia needle as a recommended, while obviously being assisted with a respiratory device?
Not that I'm aware of. We were never told that by Avery, so not that we're aware.
Barry, I don't, I guess I don't understand that. That's kind of foreign information to me.
It's the pneumonia vaccine is what it is. And it's used to,
I see. Yeah. No, I don't think I have one. Had one. I get the flu shot every year, and I just haven't had any real respiratory problems that raise that. But I have a wonderful primary care physician who really monitors my health and encourages back all the necessary vaccines. So anyway, I haven't had that.
okay, and along the same lines, this is a message from our president, Jen French, to all of you, Karen, Justin, and Christine. When it comes to respiratory infections, it's a big concern with all of us with SCI. Have you experienced any difference since you received your pacing systems versus being full-time on the vent?
Well, I went on the pacer very early, and I know that when I'm on the pacer, it is, it does provide for a more natural breathing and moisture, so it certainly facilitates the health and, to avoid being on the ventilator all the time. Hopefully that answers the question.
I would say being on the pacer, as Karen mentioned also, helps bring up a lot more secretion, which allows me to use a cough assist and get out more secretions compared to how I would on the ventilator, which I would assume would allow my lungs to be more clear, avoiding the chances of, respiratory infection. So I would say yes. The pacer just allows me to allows secretions and mucus to be cleared more effectively.
Thank you. I have a question from Chad Arnold, and Chad, actually, it was a question I had written down as well for myself. Is are there any breathing and coughing exercises that you would recommend for people living with SCI? And I open this up to you as well, Jeff. If there's been any recommendations by your physicians and things that you might practice as in terms of exercises to be more preventative from infections.
You know, can I answer that?
Sure, go ahead, Karen.
Sure.
Initially, yeah, when we were trying to figure out how to do the weaning process, just as an advice to people who were dealing with this, my daughter found a yoga instructor nearby who helped me with breathing exercises. And it was a tremendous help in trying to set myself up to be mindful of my breath, even though, of course, the pacer tells you how much you breathe each minute, but it was a tremendous help for settling and focusing and getting on a rhythm. Anyway, thank you. Sorry for jumping the gun.
Oh, that's fine. To go to Jeff now. Jeff, is there anything you recommend?
Yeah, there's one simple device that's been used forever. It's called an incentive spirometer to help with deep breathing exercises. It's a mouthpiece with a ball or a float, and you take a deep breath in and try to hold that float in a certain position as long as possible. And you repeat that 12 to 15 times a minute in a minute, and then you or in an hour, and then you repetitively do it again. That's the number one simplest way. And as Karen mentioned, she's not the only one that's mentioned yoga breathing to me from pacer patients. I have a number of them that have actually gone to yoga breathing classes online and learned how to be mindful of their breathing. Another device or method is expiratory muscle training. And these can be taught by physical therapists, not just respiratory therapists. And what is typically used is some type of device that you put in your mouth through a mouthpiece, and you breathe against some type of resistance. And by breathing against that, you're splinting open the airways longer. And afterwards, you then perform some type of secretion clearance, whether it be an inexaflator or a manual cough assist to help remove secretions.
Thank you, Jeff. Did you have anything to add, Justin or Christine?
Not really. I mean, for me, these are actually good to hear about. The only methods that I've heard, which I'm sure everyone's more or less aware of, which has helped me as far as secretion clearance, is chest PT. As I lay on my side with the help of nurse or an aide. Basically tapping on my back to clear out, loosen mucus on the lungs. But what Karen and Jeff mentioned is very informative for myself. Actually, I would just add, it says PT. If everyone's not already aware of that method. That's all.
Thank you, Justin. I have another question for you, Justin. This is from Megan Moynihan. What duration of continuous use of the Avery system do you feel comfortable using without the ventilator, and what determines that duration?
So right now, I'm on the pacer. Again, the pacer I use is from Avery. I usually wake up around 7 or 8, still on the ventilator. Switch to the pacing right before I get out of bed and go onto the wheelchair around 11 or 12. I'm usually on the pacer about 6 to 8 hours a day during the day. I switch back to the ventilator around 6 or 7 p.m. when I get back into bed. I usually get back on the ventilator overnight. Mostly, I think it's really more at this point for comfort and to use a cough assist. At which point it's switched back to med. So it's more really for comfort. Being on the ventilator is a little more comfortable.
You could speak more easily on the ventilator
Yeah,
as well.
speak more easily. I did. It's not for a lack of, I guess, being tired or being able to. I think these were issues when I first started pacing, when I first got involved with the pacer. I think if I wanted to, I think I could pacing 24 hours a day.
And you have.
Yeah, I have been.
At times, Justin's been on the pacer for 24-hour plus periods when we're in the hospital. Yeah.
And I'm on, yeah. It's more for comfort, or if I need to cough late. But on average, I would say I'm on the pacer during the day for about 6 to 8 hours. And definitely it comes to for convenience from my independence and mobility's sake. if I need to go outdoors or attend that event, being transported somewhere in the van. Yeah, so I hope that answers the question.
One of the things we've struggled with is giving Justin as fluid a voice as possible while on the pacer. And Karen, I'd love to know what your breaths per minute is set at, because your speech seems very fluid, and you know, Justin, it's hard for him to get out sentences as quickly as he speaks when he's on the vent, or you know, when as he spoke prior to his accident.
Right. I struggle with that too, because obviously your voice is such an important part of your identity. Mine set at 16 breaths per minute. And then, you know, I have a couple of different devices, and then they, you know, vary with strength. This one is the one I'm most, the one I'm on is I'm most comfortable with when I have to speak at meetings or something like that. But yeah, I'm very mindful of that. And to your point, it does seem like you've got a little bit more fluid conversational when you're on the vent for some reason, because the way the exhale works. But you know, that's a constant struggle too. Guys, I get that.
It is easier at least to change your settings on a pacer than it is a vent. At least that's how it feels for us, because the vent is like a little maneuver. Yeah.
Yeah, we don't get a lot of help with the vent and the controls and things like that. Fortunately, I have a, you know, like you, Christine, I have a smart husband who figured that a lot of that stuff out. And, you know, you really need that when you're dealing with these things.
Well, everybody, time is our enemy here today. We're already 10 past the hour, and we could probably do this for another hour or two, but I just wanted to thank everybody for coming today. And Jeff, I'm going to tell you this right now. We're going to be after you for that information on what people can do for exercises and prevention.
Okay.
I think when we post this, we'll make sure that all your contact information, if you guys are all right with that, is available. And want to reach out, he means, and really any last words. I'll start with Jeff, and then Karen, and then Justin and Christine. Jeff?
Well, first of all, thank you for everyone that's attending. There's been a lot of great information that's been shared here. The important thing for me is that you have to keep being your biggest own advocate. You have to keep asking questions. Sometimes it's even, you know, don't accept no for an answer. There's always a way. And the great thing about the consortium is you've pulled together a number of different opinion leaders and researchers, and so you're constantly looking for better ways for people with spinal cord injuries. So just keep fighting, whether it's with your care team, your insurance, whomever. Just don't accept no. That's my advice.
Good words. Karen?
Just a big thank you, and I appreciate so much knowing about the consortium. You know, knowledge is power, and you know, in my field where I worked before I got hurt, you know, it's always just been about collecting data and figuring things out. And I think that's one of the challenges with these injuries is there's just not enough collection of data to figure out what the implications of things are. And then finally, again, just to thank you to Jeff and also my admiration for Justin and Christine. I know what challenges they're facing. Thank you very much.
Thank you, Karen. That was kind words. And Justin and Christine.
Thank you, Karen,
Yes, thank you.
for saying that, and thank you to NASCAR. And thank you to all the viewers. I'm sure there are many viewers that are also like me, that may be in a similar position. I'm very happy to answer questions. I'm very much a proponent of getting this surgery, and I'm very happy I did. And I very strongly of those who are on mechanical ventilation who may be considered and maybe could be candidates for it. So if you have any questions, please feel free to ask nervously, and we'd be happy to consult with you and talk and answer any questions. A big thank you to everyone for the invitation and the opportunity to share a story. So, thank you.
Yeah, ditto to everything Justin just said. And if there are any caregivers that are interested in talking about the phrenic nerve pacer, or pacing in general, I'm more than happy to connect. So thank you, NASCIC, and we appreciate it.
Well, thank you so much for sharing your journey, your truth with us. And yes, Karen, I'm a big advocate that knowledge is power, and the fact that you're all paying it forward really to help those that are, might not have to go through the same trials and tribulations that you did. And if they do, they have someone there to hold their hand through it. I think it's fantastic. Jeff, very informative. You've all been fantastic today. This will be archived, and we will, with your permission, have your contact information for others to reach out to you after the fact. Thank you once again. Just a reminder, everybody, that you can become a member. It's all available there. There's the QR code if you need to, or you can go to nascic.org and find out how to do it there. Our next presentation is actually our quarterly presentation through SCI Connections that we have 4 times a year. And this one's a big one for all of us too: contemporary management of the neurogenic bladder, an individualized approach. And we have some great guests, Dr. Michael Kennelly and Dr. Argy Stampis, who will speak to us and share with us their learnings and what they've gone through in treating people with SCI and all in and around bladder. Thank you again, everybody, for taking the time today. So great to hear your presentation. Much appreciated. And we look forward to other great stories and presentations in the future. And for anybody that wants any information, please feel free to reach out and contact us. Take care, everybody, and have a great holiday weekend.